Top Med Talk.
Nick Geriatrician here. Welcome to Top Med Talk. This piece is taken from the Perioperative Medicine Shared Interest Group's 2018 annual conference, Measuring, Managing and Minimising Risk, which was held in association with the Australian and New Zealand Society of Geriatric Medicine and the Internal Medicine Society of Australia and New Zealand. Don't forget to check out the show notes on topmedtalk.com for more details. Have a listen.
Professor Sunil Sahai is a professor of medicine at the University of Texas MD Anderson Cancer Centre. His undergraduate education was at Tulane University, followed by medical school at the University of Texas Medical Branch at Galveston. He then completed his residency in internal medicine and paediatrics at Texas Medical School at Houston, and he's a board certified in internal medicine, paediatrics and medical quality. He's actually on the board of SPACI, which is the Society for Perioperative Assessment and Quality Improvement, and he also has completed a graduate certificate in healthcare management from the Rice University School of Business. Harry Gibbs graduated from Sydney. He then went and worked in Brisbane, but is currently the Program Director of Outpatients and Deputy Director of General Medicine at the Alfred and at Sandringham Hospital here in Melbourne, and he's an Associate Professor of Medicine at Monash University. Professor Stephan Schug. Stephan is the Professor and Chair of Anaesthesiology in the Medical School of the University of Western Australia in Perth, and he's the Director of Pain Medicine at RPA. He has a very strong research background in many aspects of pain as well as in quality improvement. He also takes some leadership roles in an international pain society. Associate Professor Vasi Naganathan, who is an academic at the University of Sydney and a consultant geriatrician at Concord Hospital in Sydney. He's actually got wide-ranging research interests with a particular focus on collaboration. So I'm going to start with a fairly controversial question, which is aimed at Harry Gibbs. And the question really is about your thoughts about continuing perioperative aspirin. And I found it interesting that a lot of people are saying that POISE-2 is giving justification for stopping aspirin before surgery, but you seem to be saying that you're using POISE-2 to justify continuing aspirin with surgery. Could I ask you to explain that a little further, please?
Sure. So POISE-2, as you know, had two arms. Those patients who were not on aspirin, and they were randomised to start it, and those who were on it, and they were randomised to continue or stop it. And if we just take those, I'm really addressing those who are already on it, and there was no difference in outcome in that group. So I don't know how you interpret that. You can say on the one hand that you don't need to continue it, or you can say on the other hand that you don't need to stop it, because it doesn't seem to make any difference. So I think you can interpret it either way, as a matter of fact. But it doesn't matter. I mean, if you sort of, it becomes slightly philosophical. If you think that aspirin seems to be good for people with vascular disease, then you can continue it, and you'll be completely justified. If, on the other hand, you think that it's not helping, then you can stop it, and you'll be completely justified.
Did you have any thoughts?
You can't lose.
Did you have any thoughts about the small number of patients with stents within the POISE-2 and how you would actually approach that group?
So I think they are a separate subgroup, and stent thrombosis certainly historically has a pretty poor outcome. It's got a pretty significant mortality, and you do want to avoid it. I think maybe that's changing a little bit as stent technology has improved. The stents nowadays have a lower risk of thrombosis than the very early stents. But I think they are a different group, and it's pretty devastating when there is stent thrombosis. So I think in that subgroup, I'd take POISE-2 to say that yes, it's fine to continue, and I would.
Some of you may wish to actually ask him more questions. Bobby?
Make a statement about that.
I think there's a microphone coming towards you, if you don't mind. Thank you, Kirsty.
Thank you. I feel pretty passionate about POISE-2. I think that it's important to remember that less than 25% of patients in POISE-2 had cardiovascular disease. So the vast majority of patients were taking it for primary prophylaxis, and we know they're a very low risk for having perioperative, adverse outcomes. And there is no benefit in continuing aspirin in that group of patients. And all you're going to do is uncover the bleeding complications. But if you take that group of patients who have vascular disease, I think we should be really, really careful about stopping aspirin. There's a rebound recovery of your platelets. We set up patients. I'm not trying to usurp the cardiologist's position, but I understand that in non-perioperative situations, up to 40% of all vascular events are attributed to stopping antiplatelet drugs. There was a subgroup analysis of the patients who had stents, and remember that less than 5% of patients in the POISE-2 trial had stents. None of them had stents in a recent period. There was a subgroup analysis that strongly supported that those patients did much worse when aspirin was stopped. So I think we need to be sure we're talking about the details of POISE-2 before we make these blanket statements of whether to stop or not stop and the risk of bleeding or not bleeding.
And I think the other thing that's really important is we need to make a decision on the individual in front of us, not just on what the trial says about a general population. Thank you. I'm going to move away to something which may be equally controversial. And Sunil, there's actually a question about whether the oncologists at MD Anderson are actually putting their patients on an exercise pathway in that cancer treatment setting.
So that's a very good question. Until 5 years ago, we were not. And I call in my talk, call them the chemo couch potatoes because they became more and more deconditioned as chemotherapy progressed. But only in the last 5 years have our oncologists actually turned around and actually focused on getting patients moving. And there is, if you look in the Google world, there is fear in the patient population that if I exercise, I move, I jiggle the tumor breaks off and goes someplace else. And there's some relative concern about having those issues occurring from sheer trauma, but it's been a sea change in the last 5 years. We're not putting them in a formal exercise program because of funding issues, but every oncologist is talking about staying active as much as you can during the neoadjuvant period.
And can I ask what the tipping point was where this change happened?
I think it was the data from the breast surgery team, and in terms of breast, we have very clear evidence that women with breast cancer, if they exercise, they live longer, have a higher quality of life, and a longer disease-free reoccurrence interval just by having 30 minutes of exercise daily or 75 minutes of vigorous exercise twice a week. And it's now made in all the recommendations. So I think that was just extrapolated to every single cancer after that point. Thank you.
Vasi, if I can move to you. One of the things that struck me about one of your outcome trials was an outcome of, I think it was 23% of fecal incontinence. And there was some work done a couple of years ago that suggested that when you ask patients who were at risk of dying what would be worse than death, one of the biggest things that they said would be worse than death was bladder and bowel incontinence. I'm really interested to hear how you assess, counsel, support patients who develop incontinence as a consequence of surgery.
That wasn't controversial. That's just difficult. That's I could just say as a geriatrician, that's a general question, right? We deal with people with urinary and fecal incontinence, so we work out, can we find a cause? But the problem is it's often not a single cause, right? It's often multiple reasons related to their mobility sometimes. So you might work out that actually if we can get their mobility better, then we might improve their incontinence. And actually getting people to, the first step is actually probably getting people to show that they actually care about this and are taking it seriously, right? They often seem bigger things to worry about, right? And so that's probably one of the first steps, is to actually ask about it and then take it seriously and try and put in a plan.
I think that's probably my take-home message from this conference is going to be, is incontinence. Can I just ask, how many people actually ask about incontinence as one of their screening tests before surgery? Because I know I don't. There are a couple of hands, but it's probably a minority question. So thank you. I thought that was an interesting and concerning statistic. We also have a question about what screening tool you use for malnutrition and how you actually promote oral intake after surgery.
Actually, Alison probably should comment about that because they've actually done that in a study. you want to comment about that? I mean, the screening tool, people talk about in research settings, the mini nutritional assessment. Most of our patients see a dietitian anyway, right? In particularly our group,
which is such a luxury.
Yes. But Alison, do you want to comment in your trial? Because that was really interesting.
I guess ours is a little different in that we do take a more systems approach. So we do have a screening tool and we actually do an MST as part of an admission nursing assessment on everybody, but certainly not all of them see a dietitian.
And so which screening tool is that?
Minority, the malnutrition screening test, which is basically have you lost weight and how much, and have you eaten poorly? So 2 questions, really. Very simple, well validated, good validation. It doesn't, what none of the nutrition screening tools predict is poor intake in hospital. So they are good at identifying malnutrition today, but none of them, MNA, MST, MUST, any of them, don't predict poor intake in hospital. So you still need to monitor intake. And one of the challenges is the complexity of the systems that we have around intake. So multiple people involved, so kitchens, nursing staff, dietetics, medical advice, all of those kind of things. So systems approaches like blanket high protein, high energy diets for older people, like actually having morning tea and afternoon tea, which most hospitals have discarded for cost reasons. These are all really important, and it's often a really complex problem to unpick and needs a quality improvement approach.
Thank you.
And anecdotally, the most useful thing you can say is, you don't have to eat this crappy hospital food. You can bring food from outside hospital.
Pizza. Stephan, a question for you, if I may. And this perhaps has some geriatric overtones as well. And the question is really, how do you actually balance multimodal analgesia in an elderly patient when you start thinking about their risks of delirium?
Absolutely. I mean, we know that pain can cause delirium too. So I think one needs to be careful to say that analgesics are causing delirium. Leaving out analgesics and having pain can cause delirium too. But clearly non-opioid analgesics, for example, are superior in this setting over opioids. And that, I think, is even more a reason to use regional analgesia techniques whenever possible. And Royal Perth has now the luxury of a regional anesthesia service with 1 consultant, 1 fellow, 1 nurse, who are available during normal daytime hours and can, for example, do all our NOFs with a femoral catheter, often already in arrival in the emergency department, which makes a lot of difference to pain quality of pain relief, but also to reduction of delirium.
Thank you. I was also really intrigued by this concept of a transitional pain service. And can I ask for a show of hands, does anyone have the luxury of having a transitional pain service in their site? Again, a couple of hands.
1, 2. Very
I'm
good.
really interested, is this the way of the future? Is this where we're going to go?
I think it is the way of the future. We are doing it a little bit informally at the moment because I can't get formal funding, but we know that, as I mentioned, Finland, for example, was one of the first. In Helsinki, A.R. Calso and Joel Katz and his associate Hans Clark, who actually was twice in Australia now lecturing about it, have both been extremely successful in introducing it, but it costs money, and that is a problem in the current environment.
Thank you. I'm going to ask one final question to Harry Gibbs. And Harry, there was a couple of questions about the role of using TEG or ROTEM for assessing bleeding risk, especially in the emergency setting. Could I ask you to comment, please?
No, I don't know the answer to that, so that's a bit too hematological for me. Predicting bleeding is difficult, and there have been a number of attempts at trying to do it, including those techniques, as well as more standard coagulation testing. But it's difficult, and I don't think I'm just not certain of the answer to that. I don't think there's very strong data to support its use, and none of these things have a very good predictive value, actually. So it's a problem. Predicting bleeding is a lot more difficult than predicting thrombosis, actually.
So if you could give one tip for predicting bleeding in the emergency setting, what would it be?
in the emergency setting, so someone who requires an emergency operation, I guess that they're a group, if they're taking anticoagulants, they have got a very high risk of bleeding, and you should do something. The tip would be to give them something.
I suppose if you ask a silly question, you get a silly answer, don't you? But yes.
The tip would be to, stick some Prothrombinex into them as they're going up to the operating theatre.
All right. Look, everybody, can I ask you to join me in giving a huge round of applause to our speakers today? Thank you so much.
Geriatrician here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com, and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.